Good evening, everybody. Thank you very much for joining us this evening. My name is Laura Nixon. I'm a family physician and researcher with the University of Calgary, and I have the honor of being your MC tonight. I am of Scottish and Ukrainian descent and grateful to have called Mohkinstsis home for 24 years. We could advance the slides, please, guys. Thank you. Just back one, please. We wanted to acknowledge and honor that those of us who are participating in this event across the province share the traditional and current lands of the many First Nations, Métis, and Inuit peoples whose resilience and presence with us remind us of our treaty obligations and relationships. The province of Alberta includes territories in Treaties 4, 6, 7, 8, and 10. Which include a diverse array of culturally distinct Indigenous peoples whose histories, languages, and cultures continue to enhance our communities and remind us of our ongoing relationships with each other and the land and our own processes of reconciliation. We do receive some in-kind support from the Alberta College of Family Physicians in the form of webinar infrastructure for this evening's presentation. And here's our list of our planning committee members, and want to put a shout out in case anybody is interested in joining our very fun group. We have some openings, as you can see, that are geographically specific, but we also welcome anybody who would like to join us from another region where we might already have representation. So these sessions, in case this is your first time joining us, are open to anyone, but are designed for primary healthcare teams, and they are a 6-time-a-year event and focusing on chronic pain and issues common to people with pain. The weekdays vary, but our time is 5:30 to 6:45, hoping to catch people at the end of their days with still a bit of fuel in the tank, and they're via Zoom to hopefully make them most accessible. You could please be sure to provide feedback by the link you'll find at the toward the end of the session in the chat box. We on the committee, as well as others in the infrastructure, read your comments diligently and all of your feedback, and we do use it to inform future planning. And you'll also receive an evaluation form later in the week. And so our process is, if you have technical or logistics issues or questions for the team here, to use the chat box, please. But otherwise, if you could post any questions that you have or comments related to the talk in the Q&A function, and you can upgrade those by voting on them to kind of help them surface to the top of the list of questions if you wish. So if you could also mark your calendars, please. Our remaining 2 sessions are, as you see on the screen, in March, pain in Indigenous peoples and an ongoing reconciliation approach, and then acceptance and commitment therapy for chronic pain and substance use disorders in May. So please be sure to save those dates. They're going to be excellent presentations. And over to the other team here.
Hello, my name is Maya. I am one of the CMN coordinators. I would turn on my camera, but unfortunately Zoom is not letting me right now, so I will just speak to it. So we would love to invite all of you to join us for the Collaborative Mentorship Network for Chronic Pain and Addictions first in-person continuing professional development event. This event will celebrate the Alberta College of Family Physicians 3-year Health Canada funded program by bringing together our silent heroes, the clinicians that have provided care for the most complex and vulnerable people in our society, and providing relevant CPD and a forum for community building and visioning to maintain professional connections made throughout the program. This one-day conference will feature engaging speakers, including a panel of inspiring CMN members and interactive workshops using human-centered design methods to explore complex topics. If you are interested in registering, we will post the registration link in the chat shortly here. And this will be taking place in Calgary. So if you are in and around Calgary area, we would love to come meet you. We hope to see many of you there. And if you have any questions, you can also direct them towards the mentorship@acfp.ca inbox. Thank you.
Thanks, Maya. So we have a poll ready to see who is in our audience today, based on discipline and your geography. If you could respond to that, that would be great, please. Looks like we have some nice broad representation in our audience, which is usually the case. So our objectives today are to focus on adapting a pain medication management plan to account for comorbid depression, anxiety, and/or ADHD, and use office-based CBT strategies to address comorbid conditions and help a patient access the best community resources for comorbid conditions. And without further ado, I'd like to introduce our esteemed speakers tonight. Dr. Amanda Berg is a psychiatrist foundationally trained in DBT, as well as numerous evidence-based trauma therapies. She consults to the Calgary Foothills PCN extended team with a focus on chronic pain and operational stress injuries in the Operational Stress Injury Clinic. She also covers specialist link psychiatry every other Monday and loves connecting with family physicians over this platform. She is actively involved in teaching psychiatry residents at the University of Calgary. She is a mom to a busy 6-year-old and 4-year-old. And I'll introduce Dr. Young as well. Dr. Kathleen Young is a family physician who works primarily at Crowfoot Village Family Practice for the past 9.5 years. She also works with the extended health team once a week, helping in a team-based approach to managing chronic health conditions such as chronic pain. She is also mom to a busy 12-year-old son who always keeps her on her toes.
All right, thanks so much for that introduction. So Kathleen and I are really excited to talk a little bit about our experience managing common mental health presentations in the context of chronic pain. Just in terms of my own disclosures, I have done some pharmaceutical sponsored CME events in the remote past. I don't have a lot of specific medication recommendations that I'll be making. We'll be following the treatment guidelines, and I think you'll see our talk is really focused on self-management and therapeutic intervention, so I don't anticipate any specific bias. Dr. Young doesn't have any specific financial disclosures or other disclosures to make either. And then, as was mentioned, the program has received in-kind support from the Alberta College of Family Physicians for the Zoom platform and no other external support. All the learning objectives were developed by the planning committee and then provided to Kathleen and I, and the planning committee's reviewed our slides. We've talked a little bit already about the objectives, and so we'll revisit these as we kind of go through each topic. We'll start out though looking at this objective of kind of thinking about how we might adapt a medication management plan in a patient who has chronic pain and comorbid depression or anxiety or ADHD. But maybe before we start, we'll just paint a bit of a clinical scenario or picture that I'll let Kathleen take over.
Yeah, so obviously, primarily as a family physician, we're thinking about who are we seeing in the office, right? Who is coming in to see us? So we're thinking about that patient that maybe comes in complaining of that, years of widespread all over body pain. They've had lots of investigations done. Everything's been normal. They complain that their life really is miserable. They don't feel it's worth living. They can't work. They can't engage with their family. And they often describe that nobody really believes that I'm in pain. All of these investigations have been normal. So that's kind of the type of patient that we want you to kind of keep in mind as we go through these management strategies and how you might approach that patient.
I think it's important to highlight when we think about patients like this, I as a psychiatrist, I'm thinking there's a huge vulnerability to depression, and that we see this highly intertwined comorbidity between chronic pain and major depressive disorder. And really, we think that these conditions are often co-exacerbating each other, that some of the behavioral changes that occur with depression are going to exacerbate chronic pain symptoms, and some of the behavioral changes that happen with chronic pain are going to exacerbate depressive symptoms. And we generally are concerned that the comorbidity can lead to worse outcomes, particularly from a functional perspective when somebody is struggling with kind of both of these conditions. And more, I think we're starting to be aware of a potential biochemical basis for this comorbidity. And perhaps this is something we've kind of known for a long time, in that a lot of our medication management there's been overlap in what seems to be effective for chronic pain to some degree, and depression. We see a lot of agents that ameliorate kind of pain and depression having action at serotonin and norepinephrine systems. So there's not only a management perspective on why it's important to kind of hold on to this awareness of this comorbidity, but also just the impacts on outcome. The other interesting thing is that cognitive behavioral therapy, which may be more familiar to many of you as one of the most evidence-based interventions for major depressive disorder, also has been shown to be effective and can be a helpful tool in managing chronic pain. And so it's not even just our medication management in terms of the overlap of what interventions are helpful, but actually some of our psychotherapeutic interventions appear to have benefits in both conditions. When we think about managing depression, we in general in Canada are turning to the CAN-MAT depression guidelines. And so really what I wanted to highlight is that within those guidelines, duloxetine is really the agent that would also have indication for specific chronic pain conditions. And so might be a medication that we would kind of consider preferentially in targeting somebody's major depressive disorder when they have certain chronic pain conditions. And then I would say off-label, we have kind of, there's research to support other agents that maybe have a similar mechanism of action, such as desvenlafaxine or venlafaxine, or some of the tricyclic antidepressants. And so often if we're not kind of successful in achieving the symptom relief with duloxetine, it's not uncommon for us to kind of consider some of these alternate first-line agents for depression in the SNRIs, or these second-line options in the TCAs. What I would say though is, as we're kind of approaching this, it's also important to keep in mind kind of expectations and have some degree of awareness that no medication is likely to kind of completely resolve depression and chronic pain, and that often we're taking a multi-pronged approach. When we think about managing anxiety, in Canada, we're generally following the Canadian anxiety guidelines. And again, if we think about generalized anxiety disorder, duloxetine would be the kind of antidepressant that we think about that has first-line evidence for generalized anxiety disorder, as well as some chronic pain conditions. The other one, though, that I find people maybe aren't as aware of is that pregabalin, which I think most family physicians are most familiar with using this medication in the context of chronic pain, that it actually also has first-line evidence for generalized anxiety disorder as a monotherapy, and then as well has evidence as an adjunctive therapy, and so is one that I often am considering in somebody who has significant anxiety and chronic pain. And then again, off-label, we can consider some of the agents that function in a similar class or with a similar receptor binding, and so that would be venlafaxine or imipramine would be the kind of SNRIs and TCAs that have the most research behind them in generalized anxiety disorder. A caution around benzodiazepines. So the guidelines are pretty cautious around their recommendations of use of benzodiazepines for anxiety in general. And I often, when I'm connecting with patients and other clinicians, I'm liking to kind of make sure that people are understanding the potential risks of benzodiazepines in patients who are using sedating pain medication. So there's research to suggest up to a third of patients with chronic pain are prescribed benzodiazepines, and we really worry about this increased risk of adverse events. The combination of benzodiazepines has been shown to be associated with a 5-fold increase risk of opioid-related overdose, and so I think it just is important for us to kind of be aware of these risks, make sure we're explaining them to patients, and kind of using caution when faced with co-prescribing these agents. When it comes to ADHD, there's certainly less overlap in the kind of medication management options. And what I would say is, if you have a patient with ADHD and chronic pain, use our best evidence-based tools for both of them. And I probably wouldn't kind of necessarily be veering towards a non-first line agent in the hopes that it'll help kind of two conditions at once. I'd probably lean towards using our first line kind of long-acting stimulant medication to treat the ADHD if it's there, and use our other kind of tools in our toolkit to manage the chronic pain. Imipramine is the one that kind of out as a third line option in the CADRA guidelines for ADHD. Honestly, my experience is that the third line agents don't tend to have a significant benefit, and that if we can, it'd be much preferable to treat using the first or second line options.
So I think one of the important things that, it's important to kind of relay to patients is being realistic about kind of what our expectation is when it comes to pain medication or managing chronic pain with meds. I think that it's really important that we are very upfront with patients, that, our focus is really on self-management strategies. It isn't on, we're not expecting the medications to eliminate their pain. Our goal is hopefully that it'll reduce their pain and help improve their function and allow them to therefore engage in better self-management strategies and, participate in their life more effectively. But that the goal is not to eliminate pain. And that's, I know, something we often see is like, I want this pain to go away completely with this medication. And realistically, that's not the goal of the medication.
So we're going to introduce a whole bunch of CBT strategies that can be part of this self-management approach that can be really effective for managing chronic pain. I just wanted to highlight that much of the strategies that we are reviewing and discussing are coming from this Managing Chronic Pain, a CBT approach workbook. Certainly we have experience in our own way of kind of explaining and kind of in real life engaging with these tools. So we will add that, but it's just a helpful resource to highlight. And just to highlight that much of what we're going to be talking about is kind of following a very standardized CBT approach. I think when we're introducing the idea of using these self-management tools and CBT strategies, we want to just be cautious and very thoughtful about our language. It's very easy to inadvertently invalidate our patients as we're kind of introducing the concepts of CBT. And this is true whether we're introducing them with respect to anxiety or depression or chronic pain. And so one of the challenges is I'm kind of presenting CBT as an intervention that's going to help with pain. And in doing so, I'm going to highlight all these connections between our thoughts and our emotions and our experience of pain. And the risk is that my patients are going to misinterpret that I'm implying that the pain is all in their head and that this is kind of a mental health condition or somehow not real. And so as I'm introducing this concept of using CBT strategies, I really want to make sure I'm emphasizing and being very clear that I believe that their pain is real, that there's no question from my perspective of whether they're experiencing pain or not, and that we're viewing all of the thoughts and the stress and the emotions that we're targeting with the CBT strategies as having the potential of adding fuel to the fire of their pain, so that they have this very real pain, and that all of the problematic thoughts and emotions and stress are adding fuel to the fire. And so one of the ways we're going to help them reduce or manage their pain more effectively is by kind of removing the fuel from the fire. They'll still likely, as Kathleen was mentioning, be some degree of pain. Our goal ends up being more around kind of managing it and having it not impair our functioning as much. So I really want to make sure as I'm introducing these concepts that I'm checking in and that I'm not having patients walk out of the office feeling like, well, that Dr. Berg, she just thinks it's all in my head. And so I will take extra time if I need to really confirm that they're getting, that their perception is that I really get the significance of their pain and feel validated around that.
We're going to introduce a really big, lots of different CBT interventions that you can use, and quite a big toolkit to you today. And it's important to really know your patient and really meet them where they're at. Not every patient's going to be ready. And so which strategies we incorporate, we need to be mindful of that readiness. So maybe all it is focusing on validating how they're feeling and doing some psychoeducation around pain and chronic pain and how it manifests. Maybe we start working with some patients around relaxation techniques, those kinds of things. Or maybe it's just we introduce that there's all these different tools that we can try and different strategies that we can try and use to help manage your pain. And maybe that's just the idea to, they're not ready to delve into them, but maybe it gives them a sense of hope knowing, there is a bunch of things out there that we can try, right? And then, for some other patients, maybe you got to start really slow because maybe the idea that there's all these things we can try might just overwhelm them and cause them to get stuck and not be able to decide what they want to do or what they want to work on. So when we think of CBT, whether it's for chronic pain or depression or anxiety or anything else, it's really taking an active approach, right? Where we're taking a problem-solving approach and we're really building awareness and kind of creating change. So there's several components. One is we're going to look at this concept of cognitive restructuring, which is really what it means is taking a look at what are our thoughts, having awareness of kind of what our thoughts look like and how they might interact with our emotions and in this case, our experience of pain, and looking at are there opportunities to actually shift our perspective or think a little bit differently. And that's this, so cognitive restructuring meaning really just changing the way we think or the way we perceive things. And could that kind of make a big difference in our suffering? And our research would suggest CBT is a very evidence-based intervention and cognitive restructuring can be a very helpful tool. In addition to this, we look at this idea of relaxation training that we can respond to both physical and emotional pain with a lot of tension, and that tends to exacerbate that state. And so we can intentionally use strategies of relaxation to try to counter that and to create relief.
we will also look at this idea of time-based pacing. And I think this is quite a focus in the context of chronic pain, though I think it has applicability to other difficulties like depression, but it's an important component for sure when we're talking about chronic pain. And then the other thing that's very kind of common when we think about CBT as an intervention is that there's homework, that generally we don't kind of think that change just happens in the hour-long or half-hour appointment or however long you have with a clinician in a week, but it's the things that you're doing kind of on a daily basis in between. And so part of the self-management work and the CBT work that we are encouraging is to be doing these practices in between appointments with clinicians. A lot of the starting place of CBT, regardless of kind of the target or the issue that we're trying to use CBT to help us with, is to start developing awareness and connections of kind of how our difficulties are kind of maybe causing problems in our life. And so when we think about chronic pain and depression and anxiety and all these difficulties, it can be helpful to start by thinking about what is the impacts of my difficulties on my activity levels. We see really commonly that pain or depression or anxiety can cause a significant reduction in people's activity levels. And this is where we can kind of end up in some of these vicious cycles. So from a pain perspective, we see a lot of avoidance of activities to kind of try in a sense mitigate pain, but this can lead to kind of deconditioning, which can then exacerbate pain. And so we also worry about that potentially increasing difficulties with depressed mood, because activation is really important for effective mood. So one of the starting places in CBT is often to start having people to reflect on what are the impacts of their difficulties on their functioning, on their ability to engage in things that are important to them. This is also going to help us then anchor into what are our goals. We don't tend to be super successful in our treatments if people's goals are to not have pain anymore. But if people have goals of being able to, spend time with family in this way or that, or, have a bit more specific goals around functioning, we tend to be more successful. We also want people to start to just reflect and think about what are the effects of their thoughts and feelings, and how do they impact each other, and how do they impact their pain. We know that how we think has a big impact on our experience of pain. If I'm kind of ruminating around thoughts of life is unfair, I'm never going to get better, it's going to have a likely negative effect on my progress in managing my pain. If I'm feeling worthless and depressed and anxious, I'm likely to kind of have more persistent struggles. And so we know, and we're going to talk a little bit more about this idea that we have significant research to support the idea that negative emotions and thoughts tend to increase our focus on pain, tend to kind of contribute to a state where we're struggling more with our functioning with pain. And so that's where targeting our thoughts and feelings can be a really helpful and effective intervention in kind of mitigating some of that fuel on the fire. So one of the helpful kind of early interventions that we think about is even building people's awareness. What are the things that increase my pain? What are the activities or the situations or the thoughts or the feelings or the states of mind? What are all the things that increase and decrease pain? And again, build that self-awareness. And what is going to look a little bit different for everybody. We also want to, there's lots of psychoeducation in CBT. And so the other kind of big psychoeducation piece is how we can kind of end up in these cycles. So this idea that if I have persistent pain, I'm more likely to have negative beliefs about pain and a lot of thoughts like this is never going to get better. I'm going to have more hopeless thoughts. The more I have these really negative thoughts, the more I'm likely to have negative emotions, like I'm feeling worthless, feeling depressed. And all of that is going to come together and create impairment, disability, loss of functioning. And then all that impairment is going to lead to this avoiding of activities, and kind of deconditioning, deactivation, which then is going to make me more vulnerable to potential pain, more vulnerable to depressed mood, and the cycle can kind of perpetuate and kind of escalate over time. And so what we're really looking to do is use these CBT strategies and self-management strategies to interrupt this cycle.
Yeah, so a lot of that, again, is a focus on like, what are our goals? Like, can we take the patient's kind of mindset away from the elimination of pain, and like, what are their goals? Like, how do we reduce the impact on your daily life? How do we learn some skills to cope with pain better? How do we improve like your physical, emotional functioning, and reduce the reliance on pain medication and kind of those passive kind of treatments, and get more, allow them to get more active in that self-management strategies. So the next thing we want to talk about is a little bit about kind of how we approach or talk about kind of chronic pain and chronic pain theory. So kind of the old way of thinking was this, specificity theory. So kind of the amount of pain a person feels is directly related to the amount of tissue damage that's occurred. And so the pain will stop when the damage stops, when it's healed. And we, I think probably this group is well aware that there's lots of problems with that theory that we know from lots of examples, such as like things like phantom limb pain, or the fact that similar people will have a similar injury but have markedly different levels of pain, right? That the tissue damage and stuff like that is not actually a good correlation when it comes to the amount of pain or the amount of suffering that people are going through. So we want to kind of move towards the new theory, this gait control theory. So it was developed back in the 1960s. So it has been around quite some time, but the importance of the mind and the brain in how we perceive pain. And so when you're injured, a signal travels from the site of the injury through those nerve fibers, and up to our brain. And then our brain then interprets the signal. And you perceive pain. And so there's this idea of there being a gate. So a gate in the spinal cord that can open and close depending on the inputs it's getting. And that the opening and closing of that gate modifies how much information is sent to the brain, and therefore kind of how much that pain is either magnified or dampened down. So kind of like we were talking earlier, like of adding gasoline to the fire, negative thoughts open that gate and really let more pain information through. And positive thoughts, will help close down that gate and restrict the kind of the signal that's kind of going to the brain. So a lot of the focus of a lot of the stuff is on how can we reduce those signals on the way, or even block those signals, and what kinds of things intensify it. So we know that patients who are very pain focused, they're holding that gate open, right? They're getting those increased signals and amplifying that signal in their brain. We know if, I'm sure many of us have experienced, if you're bored or unoccupied and you're having a pain in some part of your body, you will notice increased pain. But if you're distracted or doing something enjoyable or fun, that you often, the pain is less noticeable, right? So some of the things, again, that open that gate, we know are continuing muscle tension. One of the things we'll talk about is those relaxation techniques, degenerative changes, so actual physical changes in our body, drug abuse, it holds open that gate. like I said, that attention to pain, beliefs about the pain being something horrible or, dangerous to them, again, will open up that gate. Our emotions, right? Anger, depression, fear around, what could be going on with my body. It's interesting, we often talk to patients and they'll tell me that too much activity makes it worse, but too little activity makes it worse. Other poor health choices and behaviors, having an imbalance between their work and their home life, or their, being able to do the things that they enjoy. People who don't have a good social support network, others kind of focusing on their pain, those around them, or, people around them kind of, trying to protect them too much, and being like, oh, you shouldn't do that, and kind of, again, refocusing them on that pain.
So we want to teach our patients to all kinds of tools to help close the gate. And so as we go through these tools, I just want to highlight, we can use these as standalone interventions. So I might have a patient who, I cherry pick one intervention and we work on that. I might introduce them in a series. I might also recognize I don't have the capacity to teach all of these tools and skills as myself, as a clinician working with this patient. So I'm going to rely heavily on education groups, YouTube videos you'll see, books, websites. So what are the other resources? So we'll try to speak to that as we go as well. One of the first things that can be helpful to introduce are relaxation strategies. And these are highly accessible. I don't have to spend a lot of time teaching relaxation strategies in clinic. I can refer people to YouTube with some keyword searches, and really it's about having the conversation about the benefits of investing the time in these strategies. So I'll talk to people about how if we practice relaxation, fundamentally, I actually think what we're doing is combating chronic stress and the kind of toxic effects of chronic stress. But we can look at the potential for really reducing muscle tension and fatigue, which can be helpful from a chronic pain management. There's research to suggest we can start to lower blood pressure, certainly decrease some of the experience of pain, have increased energy. I think a lot of people will tell me, I don't have time to slow down and relax. And so sometimes we have to talk about, if we actually take care of ourselves and get ourselves into a better state, we actually may be more productive and effective than if we are constantly kind of running in this hamster wheel, constantly in a depleted state. So the first relaxation strategy that we often think about in cognitive behavioral therapy is diaphragmatic breathing. So this is a breathing practice where we're trying to kind of breathe deep into our diaphragm, kind of having our stomach kind of protrude in and out as we breathe. This is a breathing practice. There's like lots and lots of guided versions and explanations that I will refer to people to at times. But I also just like to highlight that I don't think we need to be dogmatic about the type of breathing strategy that people use. I think a lot of breathing strategies can be helpful. So if people enjoy like 4-7-8 breathing is a popular one. I think a lot of people's smartwatches now have breathing apps. And for a lot of people, that little ding of their watch to cue them, hey, do a breathing exercise seems to be a helpful piece. So I don't know that it matters so much which type of breathing exercise they do, but the fact that they're carving out a little bit of time to do a mindful breathing practice, I think can make a big difference. When I'm recommending this, I'm recommending people generally do it every day. To build that skill. My own personal practice is I try to do this 4-7-8 breathing, which again, I'll refer people to YouTube for instructions on how to do, but I try to do that every morning before I reach for my phone, try to interrupt the pattern of quickly looking at my phone every morning with a breathing strategy. So trying to help people also figure out how am I going to incorporate these strategies into my daily routine. Progressive muscle relaxation is my favorite a relaxation strategy. And again, my clinical practices, I tell people about it, and then I say, go on YouTube, type in progressive muscle relaxation, find a video where you don't get irritated by the person's voice and you like the length of the video and the progression. But basically, progressive muscle relaxation is a really effective relaxation strategy where we're going to alternate tensing and relaxing muscle groups to achieve a greater state of relaxation than we would have been able to had we just engaged in intentional relaxation. And so it can be really helpful in countering some of the tension that comes with chronic pain. It also can be super helpful in countering some of the tension that comes with anger, anxiety, and other emotional distress. And so this is another one I really encourage people to practice regularly. I often encourage people to build this into their bedtime routine as part of their wind down relaxation. And then also to do it anytime they're noticing particular tension or stress. Visual imagery is another relaxation strategy. I would say it is a very effective strategy, but takes a lot of commitment and isn't easy out of the gates. Whereas when I introduce progressive muscle relaxation to people, usually people feel a little bit better the first time they try it. Visualization can take a little bit more practice to master, but we certainly have really cool research to suggest that we can shift our emotional state with visualization practices. And so again, often a helpful starting place is doing a guided imagery in a mindfulness app or YouTube. All right, so once we've kind of nailed down relaxation and have developed some healthy habits there, it can also be helpful to start to think about and develop awareness of what are my thought patterns and what do we call these automatic thoughts look like. So in CBT, we talk about this idea that everyone has these automatic thoughts. I'm in a situation, I experience something, maybe I experience a twinge of pain or I experience a stressful event. We all are going to have this automatic thought kind of pop up in our head, and that is often going to drive our reaction, our emotional reaction, and often can drive our experience of pain. So we want to start to become aware of what are my automatic thoughts? What are the thoughts that kind of just pop up automatically in response to stress or pain or difficulty? And then I want to develop a bit more awareness of how there's links between my automatic thoughts and my emotions and my pain. And start to kind of notice it's kind of the initial work of, when I'm thinking, I have a twinge of pain, I'm having really negative thoughts, that my emotions tend to be more negative and my experience of pain tends to be worse. And so again, starting to develop this awareness, this thought might be contributing to keeping the gate open, might be contributing to me suffering more. The idea is that certainly there are events that cause painful emotions in our life, but often it's our thoughts about the events or the experiences that really drive emotion. And so that's like a core tenet of CBT, and that's part of the awareness we want people to kind of develop. We talk about this idea that all human beings are prone to what we call cognitive errors. So this is where we have these automatic thoughts, but they're not actually accurate or factual, or there's missing information. And so we can have this cognitive error that can really drive our pain and our emotions. And it's kind of based on this inaccurate thought. So there's a whole bunch of kinds of inaccurate thoughts. And so some of this may be familiar to you, right? You may have heard of like black and white thinking or all or none thinking. And so these are all there's a whole bunch of different kinds or different ways that we can have inaccurate thoughts. And to be honest, clinically, obviously I know all these, and I have lots of patients who find benefit in doing learning CBT, learning the difference between all of these different types of thoughts. But clinically, I also find that if I can help patients kind of even just identify, there's inaccuracy in this thought, or this isn't the full picture, and start to become more precise in their descriptions, that alone can actually start to help kind of do this cognitive restructuring or help them look at things differently, and that can shape their experience of emotion and pain. So the model is basically that there's going to be an event, and that event is going to cue this automatic thought or this belief, this thing I'm going to tell myself, and then that's going to result in this case, potentially painful emotions and pain. And so just as an example, if I bend over to pick up a package and I get a big increase in pain, I might have just this automatic thought, why me? What did I do to deserve this? Now I'm in for just a miserable day. My day is ruined. And that thought is going to drive this emotion of frustration and anger. It's going to make me have kind of tension and feeling hot and flushed. It might change how I behave. I might walk more slowly so I don't cause more pain. And all of that can have these ripple effects on my experience of both emotions and pain. So one of the things I try to do if I'm working with somebody on kind of catching some of these negative thoughts and kind of connecting with their pain is when we're chatting, I'm kind of listening clinically. I'm on the listening for some of these negative thoughts that I think, might be potentially increasing their experience of pain. And so if I hear people saying, I can't cope with this, my pain is going to kill me, this pain is too much for me, I can't do things because of my pain is getting the better of me, I can't do anything right. It's not necessarily that I'm going to jump on every one of these every time somebody says it, but I'm certainly going to tuck it away in my kind of conceptualization of what's going on for them as a potential area that I might want to introduce targeting, or I'm more likely to think about how can I introduce some of these concepts of cognitive restructuring or looking at our thoughts and how they interact with their pain. So let's say I have a patient who's, telling me, I just can't do a thing because of my pain. In a perfect world, I might send this person for CBT and they might learn how to do a thought record and do this formal cognitive restructuring. In reality, though, I might not have that time and the resource. So clinically, what I'm actually likely to do is just ask the patient, okay, what are the things you can't do? Let's get a little bit more precise and factual about what the difficulties are. And they might say, well, I can't keep the house clean and cook for my family the way I used to. And I could even dig even further. Let's be really kind of specific, how many times were you vacuuming before or whatever. CBT likes to get really precise. And then I'm going to push for the other side, right? So for sure, there's a kernel of truth. There's things you can't do anymore. What are the things you can do? Is it really true that you can't do a thing? Because that's a pretty extreme statement. So I'm listening for those, and I'm just trying to gently challenge and see if I can pull out facts that would suggest that maybe that's not entirely true. And so they might be able to say, well, I can, generally keep up with the laundry and I can cook a simple meal, especially if I get some support, with the dishes or things like that, right? And so we're trying to build just a bit more factual kind of thought. So I might kind of reflect back, it sounds like although it's difficult to clean and cook to the level that you did before, you are finding ways to adapt and prioritize. And so it's not about being super positive and oh, you can do everything you want. It's about kind of helping people find that middle ground of what actually is reflective and trying to filter out some of that kind of extreme thinking.
So we know that stress management can be a really important piece in managing pain, because we know as our stress goes up that our pain level kind of goes up as well, which in turn increases our stress, and it becomes a vicious cycle. So some of the ways that we talk about stress and chronic pain are some of the ways we talk about stress management in any other situation as well. So things like, making sure that we're, eating healthy, watching our caffeine intake, making sure that we're not skipping meals or, having really irregular eating patterns, making sure we're getting some form of activity. Obviously in chronic pain, that might look quite different than it might to somebody else. making sure that we're trying to kind of focus on maximizing our sleep and as best we can, taking breaks, taking time out, making sure that you're still doing activities that you enjoy, incorporating those relaxation exercises to help manage their stress. And, look at changing the way you approach things. When you're dealing with chronic pain, maybe there are different ways, kind of that problem solving of different coping strategies, like the way you manage it might look different now. And how do we change our approach now that you're struggling with chronic pain where maybe you weren't before? I think, this is kind of what we focus on, this idea of like, we need to make sure that we kind of try and focus on realistic expectations. Often patients will be like, well, I want to be able to do everything I was doing before. And I think, creating those realistic expectations, helping them to kind of keep a sense of humor. Quite a number of the patients we deal with actually have a great sense of humor. You just got to dig sometimes a little deeper to find it. Trying to focus on the things that they can do, focus on those positive things, help them look at kind of what supports they do have and how to access them and kind of maximize the support structures that they have, as well as kind of just like we talked about with those cognitive restructuring skills, like challenge those negative thoughts when they come, and how can we, not necessarily think everything is rosy, but kind of look at kind of what things can they do, what things, what are the good things in their life. So one of the things that we spend a lot of time focusing on is this idea of time-based pacing. It's probably one of the things that a lot of the patients struggle often the most with. I think as human beings, we want to just keep going and and especially if they're having a good day, they want to get as much done as possible. But we find that then they pay for it afterwards. So the idea of time-based pacing is that, we're trying to minimize the amount of times that they're getting flares and causing severe pain that's then having them to rest and not do things for extended periods of time or days after they kind of do kind of more than they maybe should be doing. And so because they get into a vicious cycle, I often call it a crash and burn. They have a good day, they do too much, and then they crash and have days where they can't do anything. And then that wears off and they have another good day and they do the same thing and they get into this repeated pattern. And it becomes quite a problematic cycle for them. So we base activities on time. So you identify a task, how long does it typically, can you do it before your pain starts to increase? And we kind of say, well, you need to back it up from there. And so your active time should never, cause you to kind of go into that increased pain. And then you kind of make sure that you're taking those rest times. And over time, the goal is to start to increase the amount of active time that you have, but it's in a very paced and slow way. And it takes a lot of practice for patients, but they do get there. So one of the other things is the importance of kind of looking at their schedule and adjusting the schedule as you go. Avoid rushing or scheduling all their appointments and stuff on the same day, trying to kind of pace things out so that they're not doing everything at the same, all in the same time, and trying to work on kind of those periods of rest where they do breathing, they do relaxation, they're taking the time to rest in between their active time. I kind of talked a little bit about this, but looking at their activities and trying to plan them out is really important, because I kind of talk about you only have so much that you can give each day. So trying to plan things out is really important, and focus on kind of prioritizing the things that they really have to do, and then kind of negotiating, maybe things that are a lower priority, maybe you space them out for other times.
The other thing that I think it's important to think about when we're talking about pacing and scheduling is it all demands and all things we need to do, or is there room for pleasant activity scheduling? So this is a huge part of CBT. And it's that idea that, if we're going to have a life worth living, if we're going to be motivated to work towards goals in our life, we need to have some degree of pleasure in our lives. And so even if we have limitations and chronic pain is interfering with our ability to do some of our pleasant activities that we've historically done, it's really important for us to figure out what are pleasant activities that we can do, or how can we modify our previous kind of valued activities in a way that we can engage in them. So all CBT books and online, if you Google pleasant activity lists, there are lots and lots of ideas out there. This is just a handful or some of the ones that come from this particular CBT book, but lots and lots of therapies have this pleasant activity kind of planning as part of the treatment. And so one of the things that can be helpful is to kind of have discussions with people about what are the things that they could do that would elicit positive emotion, and then genuinely give them homework to kind of start integrating those into their life where they can. And sometimes we'll look at that in the context of pacing to kind of find that balance as well. The other thing that I think is helpful just to keep in mind is anger can be very exacerbating of chronic pain. And so sometimes it's building awareness about that. Sometimes it's about actually getting people additional tools and support around learning skills, around anger management. And so sometimes that means referring to anger management groups or skills-based groups. Sometimes it's even just highlighting the link.
So one of the things that often exacerbates pain is if people aren't sleeping well, and if they're in pain, they're not sleeping well. And so I think lots of us have a very good understanding of the basics of sleep hygiene. I won't go through all the tips, but it is important to kind of focus on that as opposed to patients relying on medications. And probably the thing that has the best evidence is the importance of getting up at the same time every day, regardless of when you've gone to sleep. The best intervention that we can kind of really drive home with patients is the idea of they need to get up at the same time every day, even on weekends, even if you were up half the night or the whole night, that getting up and out of bed at the same time is really important.
So obviously this toolkit is vast and it's impractical potentially for us to be kind of walking patients through all of these tools. And so I just wanted to speak to some of the resources that are out there that we rely on heavily to help kind of provide a lot of this psychoeducation.
So one of the resources here in Alberta that I really recommend to my patients often is the Alberta Healthy Living Program. They have lots of educational programs around various types of chronic pain, breathing strategies, stress management, all of those kinds of things. And this allows you to kind of not have to spend, hours kind of teaching patients about that. It's a great thing to refer your patients to, and then have them come back and talk to you after they've been to the class and kind of go through what they've learned and how if they can apply it to their life.
And similarly, CMHA has a program called Recovery College. They have all kinds of groups and classes that kind of can go into more depth around kind of sleep hygiene, cognitive restructuring, and mindfulness. And so this is just another resource that I'll often refer patients when I can recognize these tools would be helpful and maybe I've introduced them. I'll kind of refer them here to get kind of more in-depth learning. Another helpful resource for patients who are maybe not so keen on joining a class or a group is the Centre for Clinical Intervention. This is funded by the Australian government. It is basically a free CBT resource. They have tons of workbooks for all kinds of difficulties, and really go through in detail and kind of offer a self-management kind of resource for learning CBT.
Here are some of the websites that we often recommend to patients. Tame the Beast is a great one that focuses on chronic pain. The Arthritis Society, if they're struggling with various like arthritis, that has great resources as well. AHS has a chronic pain management lecture series that they can access on YouTube, as well as mindfulness that can be helpful for patients as well. So different websites that might be good resources. So just to kind of follow back to that patient that we talked about, I think the key points to consider is just the importance of validating your patients and communicating to them that you really understand that they're suffering, and explain the connection between their thoughts, their emotion, and their pain in a way that continues to validate that experience. Consider the different factors that are impacting their experience of pain, and introduce tools that kind of target what's affecting them as the patient's ready to kind of accept them. And understand that we don't need to do this all in one visit. You're not going to be able to, that it's going to take time, that it's going to take multiple visits, and there's going to take resources than just you. That's why we often talk about the idea of a team-based approach to this, because it really does take multiple resources. No one provider can help manage patients' chronic pain.
Okay, thank you very much, Amanda and Kathleen. Can you hear me actually?
Mm-hmm.
So thank you for a wonderful presentation with lots of good, very practical resources for pain management. And I'm even now thinking, like, if you should start prescribing your patients to buy this book, to read it, to follow up, just as you are prescribing other medication. I believe it will cost less, and they will have more benefit from it. So yeah, wonderful. I'm really glad that I made lots of notes for myself like today from this presentation. So thank you, even for me. Okay, so let me open the questions, answers. I have one in our chat room. So can you please talk about TCAs with patient with impulsivity and emotional regulation?
So TCA, so there is a little bit of evidence for TCAs in a whole bunch of, like, most conditions. TCAs are very old. So most conditions in mental health have had some sort of studies suggesting some limited benefit. And that would include chronic pain. I would think chronic pain actually might have a little bit more data behind it than many of the other therapies. In terms of like impulsivity, particularly in the ADHD realm, my clinical experience is that it doesn't make a huge clinical difference. Certainly there's research to suggest, some shift in scores, some measurements, but clinically I haven't found it that significant. And so sometimes, though, I do think that, part of a patient's journey is trying medications. TCAs come with quite a bit of side effects, so they're not for everybody, but sometimes we go through that process and they find a little bit of benefit, or at a lower dose, they can tolerate the side effects. And so I'm supportive of that if if that's what in Wise Mind or collaboratively we're kind of coming to. I think the challenge is that the likelihood of this solving the problem is low. So if I'm prescribing a TCA in the hopes that it's going to kind of help with somebody's emotion dysregulation and chronic pain and impulsivity, I want to be transparent around the magnitude of effect that we would likely kind of expect from that. And I want to be delivering that message alongside messaging of the importance of emotion regulation skills, mindfulness, and some of these other tools that I really do see as, when people are able to integrate them in a consistent way, having a huge impact.
Thank you very much. Now I'm checking our Q&A, and there is one question actually that was upvoted. Why is counseling patients to get up at the same time every day, regardless of when they went to sleep, considered to be one of the most important sleep hygiene counseling points?
Yeah, so this comes out of research from so there's an intervention called cognitive behavioral therapy for insomnia. And this is the most evidence-based intervention for insomnia. The data for this intervention are way better than any sleeping pill on the market. And yet it's very frustrating because it's not easy to refer patients to this intervention. But when they've kind of broken down and done like sub-analysis of people who've gone through and looked at the components of cognitive behavioral for therapy for insomnia, the component with the kind of biggest signal for change is actually having a structured, consistent wake-up time. And this kind of fits with what we would expect given how we think of kind of insomnia. And so the idea is if I have a terrible night's sleep, let's say tonight I go to bed and I'm like all anxious about how did my taco, what were people judging me, right? I can't fall asleep and it's 4 a.m. and I'm still awake. And then in a parallel universe, let's say I don't have to wake up in the morning and don't have to be at work at 8. So let's just pretend I can just sleep in till 11, because by time when I finally fall asleep, it's 4. And so I had a horrible night. So I'm going to go really easy on myself. I'm going to sleep until 11. And then the next night, I'm going to go to bed at 9 or 10 o'clock when I normally start my wind down routine. And I'm not tired at all. I haven't built any sleep drive in my body because I've only been awake for, 8 hours or whatever it is, right? So then I have a horrible time falling asleep the next night, and I can kind of fall into this perpetual pattern. So CBTI principles would say you're much better off having a terrible day. Yes, you didn't fall asleep. You only got 2 hours of sleep. That sucks. But just push through your day, and you're much better off being able to then be very tired, fall asleep at 9 o'clock that night, and kind of get into a better sleep routine.
Okay, thank you very much. Next question. How can I encourage people to set functional goals rather than pain cessation? My patients are often very resistant to this idea, and I understand very well. They are here, please take this pain away from me. I don't want to live with this. So, and you are now forcing me to be more active and to do stuff that are actually causing the pain.
Do you want to jump in, Kathleen? Do you have a...
Sure. This is probably the toughest thing. So yeah, I'm not surprised you're struggling with your patients for this. Everybody's in a different place. And I find, the idea that we talked about, you got to meet them where they are. I think sometimes it's a matter of planting those seeds each time, and just trying to address it, and kind of every time just try and refocus and shift them away from focusing on the pain and focusing on like, how can we improve your function? How can we, get you kind of more functional and stuff like that. And sometimes it's hard. Sometimes when we see patients in extended team, they can't vocalize any goals for us, any functional goals. So sometimes it's going to take a bit of time to work on them, working towards those goals. There isn't any magic statement that's going to work, unfortunately, with everybody. But I think too, taking a values-based approach, what's important to them in their life? Do they want to, play with their kids, play with their grandkids? Do they want to be able to go back to work, even if it's part-time? Do they want to be able to volunteer? Like, what is something that's important to them and brings value into their life? Maybe there's a hobby that they want to do. And how can we, therefore kind of focus on it by kind of, again, focusing on like what's important to them in their life, and how can we maybe approach the goals that way?
Mm-hmm. Yeah, thank you. And I believe that kind of the following question is now little providing some answer to the previous one. How do you explain the theory of gate control therapy to patients in a sensitive manner that minimizes the risk of them feeling offended or invalidated?
I think this is where a team approach, I think, is helpful. I think we're all going to develop our way of explaining pain, and we want to be receptive to feedback. So I think there is a checking in process, getting them to kind of explain back to us what they're hearing. But I also think this is where a lot of us would be like, go to the Tame the Beast website and watch the videos, go to the Explain Plain classes and hear what they, right? Like, so this is where I also think, not having the messaging just coming from one individual, but the more that they can kind of hear a variety of people describe it slightly differently, and that repetition, that's, I think, tends to be, I think, where we end up seeing success of the extended team is that kind of slightly different, people just have slightly different ways of explaining it. And some of the resources that we'll share with people have different ways too. So that can be approached, because the reality is sometimes, no matter how delicately I explain this, people might have had past experiences that inform and how they interpret the current, this current experience. And so I don't always have full control of how somebody's perceiving my words. And so I also want to recognize I might actually do this really effectively. And there's a whole bunch of other factors that drive that misperception. And so that's where spreading it out, I think, can also be helpful.
Yeah, hear the same message from the several members. It's always helpful, and everybody perhaps would use different words. So perhaps one of them will be the seed that can start actually growing, and people can accept it and have the aha moment. Okay, now I know why I'm doing this. Now I understand why they are forcing me to be more active, because that actually creates a little bit more positive experiences that will start affecting my pain perception. So somewhere there. Yeah. So I have a few, or this one is kind of a little bit technical question. Is gabapentin interchangeable with Lyrica for anxiety that also has chronic pain benefit?
So it's a great question. So the data certainly isn't there for gabapentin. It is there for pregabalin. And I would say most of us would have a preference for pregabalin from an anxiety perspective. I think the side effect profile of gabapentin can be a little bit more concerning, and so generally, if our kind of goal is to kind of co-manage anxiety, we're really strongly preferring pregabalin. However, I've been in situations where patients have tried pregabalin, not tolerated, or they don't have coverage for pregabalin, but they can get coverage for gabapentin, and so certainly, I think in an off-label capacity, people have tried gabapentin as a kind of last resort when pregabalin wasn't an option.
Yep, thank you. And I have one more question related to medication. How do you explain to a patient that taking cyclobenzaprine, zopiclone, and BDZ are not helpful for their anxiety and pain in the long term when it causes sedation and reduces social and physical and cognitive functioning? Again, like how to be nice, how to be sensitive, and how to nicely say, no, this is not good for you, even if you feel that it is.
I think part of it for me is I try to separate the conversation of me saying no and me expressing concern about all of these. So I try to kind of separate, okay, I'm just giving you psychoeducation about why I'm worried about your particular cocktail of medication. From an anxiety perspective, I talk a lot about how we have lots of data to suggest anything that numbs anxiety, and all of those things would do that. So would cannabis, that in our long-term studies show that anxiety gets worse over time. And it makes it's very logical why that is. It's interrupting our natural exposure experiences, and it's causing anxiety to kind of grow and grow and grow. So I really try to communicate to people that we have solid research that anything that numbs emotion basically makes anxiety worse. And so if you're coming to me, if the reason for your visit is anxiety, then it's really important that I make sure you're aware that the cocktail of medication that you're on is actually making your anxiety worse. And if you want my help in managing your anxiety, I can do that, but it's going to be really hard for me to help you with this cocktail. And so I try to plant the seed of, really, if we're going to make gains on your anxiety, we got to work on this cocktail. I try, especially if somebody's been on benzos for like 20 years and right? Like this is not going to be this is a project, right? So I'm thinking like maybe in a year I'll have done enough psychoeducation that we can start peeling away some of this medication. Like, so I think having a long game is also, we just need to be realistic as clinicians about how quickly and what change we can expect. And so I think sometimes it can be tricky with the college. We can feel this pressure. We can't have these, they're telling me all these prescriptions I'm writing and this is all stressful. So I want to get people off this stuff. And I think it's good, but we also don't want to like make people feel kind of like alone and no one's helping them and nobody cares and nobody gets it. So we need to, I think, try to find a balance. And so for me with patients like that, I'm trying to plant seeds and think long game. What is the long game? How are we going to work towards this? If we don't change their prescription at all today, but I've kind of planted the seed, how can we kind of, and then obviously I'm charting all of that, right? Because I still worry about the college and why do you have this person on all this medication? And I'm like, I inherited them this way. This isn't fine, so I think that's where some of this stress around that comes from. And so I think for me, slowing down, yes, we are actively trying to manage this and it's really hard to manage. It's I think the hardest things we do.
Yeah, so I think that the answer is slowly but surely, respecting the stages of change. Like if they are in pre-contemplation, just make sure that they have enough information, how to get ready and how to start this process. Make sure that they feel safe through the whole process. They are not being forced. Everything is okay. We will respect your pacing and eventually you will feel better. So definitely something like that. Okay, well, thank you very much to all of you, Amanda, Kathleen, for being with us today, for all the important information and really very, very important, very practical presentation. I love it. And hopefully we will see you sometime again.
Thank you so much, everybody. Thanks for all your wonderful questions.
Thank you.
Thank you.